Mr. Chairman, ladies and gentlemen, good afternoon, and thank you for the opportunity for speaking today. Now, when I agreed to do this, I didn't realise that we had the graveyard shift of the ICS, and I do appreciate that this talk here is the filler between the interesting paediatric and interesting ageing bladder talks. Now, an interesting thing happened to me on Wednesday, which made me rewrite my presentation. I arrived and I was given that lovely gold ICS badge. And when I questioned Ava what it was for, she essentially told me, it's because you're old. And this got me thinking. I can still remember my first ICS back in 2007. And I just thought to talk about my experiences of the ICS back in 2007 and where we are now. So this talk will be a talk about the basic physiology of the bladder, how that was developed. I'll show you some pretty slides, and then unfortunately, no apologies for this, my conclusions are going to ask more questions than give answers. So if we I've nothing to declare apart from the genius of my co-presenters. So the traditional concepts of bladder physiology 10 to 15 years ago, we were taught that the bladder fills at a constant low pressure. There's passive stretch receptors giving us a first normal and strong desire to void, and that all contractions during filling were pathological. And this was the sine qua non of detrusor overactivity. Based on these thought processes, we gave antimuscarinics with a view that they decrease contraction, therefore reduced detrusor overactivity and affect urgency. Now, we're moving away from this concept, but this is still taught in medical schools, and it's a NUGGLE concept. For those who read Harry Potter, that stands for non-neurological, non-gynecological folk. So what we had using hematoxylin staining was quite a sparse function and anatomy to the bladder. And physiologically speaking, there was just the pain and stretch receptors directly communicating with the central nervous system, resulting in detrusor contraction. However, with this basic sign concept, the clinicians started to point things out. Alex, back in 2003, pointed out that not everybody with OAB has detrusor overactivity, and 46% of people did have something called sensory urgency. Hashimoto pointed out that patients without detrusor overactivity responded equally well to antimuscarinic medications. Additionally, not all contractions during filling were symptomatic. So the clinicians threw the gauntlet down to the basic scientists and asked three fundamental questions. Why are antimuscarinics effective in OAB, but not when there's an absence of detrusor overactivity? Why do 50% of people with OAB don't have detrusor overactivity? And why do asymptomatic volunteers have contractions? So basic science answered these questions by essentially going back to basics. This was one of the approaches. Basic science asked itself, what does the normal bladder do? And there was some chap back in 1892 which showed that the bladder wasn't quiescent, wasn't relaxed. And this is an example of a cat bladder as it fills. So with increasing volume, we can see that there's regular rhythmic contractions of the bladder unrelated to micturition. We've studied this non-micturition activity in other animal models, and we did try and reproduce these experiments in humans in Edinburgh, but unfortunately Lawrence wouldn't fit into the bell jar. What are the relevance of these non-micturition contractions? Now, each of these contractions of the bladder is related to a burst of afferent activity, but the conscious state does not interpret or acknowledge these afferent firings. What happens when the bladder fills? Well, we see as the bladder fills, non-micturition activity increases in frequency and amplitude, suggesting that afferent activity from the bladder increases with bladder filling. Now, by no means am I saying that non-metrician activity in the bladder is the only cause of sensation. I'm just saying that this, from the basic science perspective, we use this as a physiological mechanism to test certain things. We found that this activity is very sensitive to the effect of muscarinic agonists. We see purinergic response with this activity. We see an effect with calcitonin gene-related peptide. We see that there's also an adrenergic response. So basic science responded by telling us that actually there's more to the bladder than just C fibers, there's more to the bladder than just stretch receptors. There seems to be a degree of urothelial modulation. There seems to be a very intricate motory sensory network going in the bladder. And this also led to Drake's theory of peripheral modulation. Now, since the physiologists told us what the bladder can do, those with fluorescence immunohistochemistry started hunting for the mechanisms which may account for these findings. In essence, we were trying to relate structure to function. As you can see, hematoxylin gives us a very boring view of the bladder, but when we do look at the bladder in more intricate detail, we really do see that it is a thing of beauty. Here we see a staining of green is nNOS and red is essentially prostaglandins. As we can see in the urothelium alone, it isn't one discrete layer. We see three discrete layers. We have a basal urothelial cell, strongly positive for prostaglandin-releasing cell mechanisms. We see interurothelial cells, and we see superficial urothelial cells, all morphologically different. And beneath urothelium, we see a beautiful, dense network of interstitial cells, analogous to the interstitial cells of Cajal. In the bladder, we can see ganglia, staining for adrenergic receptors. We can see ganglia interfacing between acetylcholine-releasing nerves and CGRP-releasing nerves. Beneath urothelium, we can see afferent C fibers. We can also see a lovely interplay between sensory nerve fibers containing CGRP and those containing acetylcholine. And this has led to basic science turning round and telling us that the bladder really is a lovely, complex organ. This is another bladder schematic diagram, which with the research just this week, we also need to add in the urethra. Certainly work out of Pittsburgh has shown that there are now serotonin paraneurones with the urethra, which are probably adding to an additional layer of complexity. So, over the past 10 years, we've seen a strong improvement and a strong development of the basic science arm. But me as the clinician, what's happening clinically? Unfortunately, I started my urological training, my residency, my registrar job back in 2006. I'm still having the same conversations with the majority of my patients 10 years later. Nothing really has changed. Admittedly, we're sending more for SNS, and the last time I did a chlamydia cystoplasty was about 5 years ago. We have had the development and introduction of mirabegron, but has that changed the game? No, I don't think so. So, have we stalled? Have we reached a clinical impasse? As basic science, is that the one marching on and leaving the clinical side behind? Now, I've put this up. Is history repeating itself? We found very analogous to muscarinic receptors, the antimuscarinics. Mirabegron doesn't seem to have an effect on the motor side, but basic science has pointed out there are areas with which mirabegron may be acting upon. Now, the take-home, and I think the most important thing from this slide is that, yes, we know that mirabegron works, but more importantly, in whom does it work, and also in whom doesn't it work. So 10, 15 years ago, we threw the gauntlet down to basic science. Has basic science turned round and thrown the gauntlet down to us clinicians? I think the bladder is trying to tell us that she is infinitely complex. De novo, it has a number of mechanisms that potentially could go wrong. Furthermore, it's with this lovely intricate interplay with all these mechanisms, it is susceptible to up and down regulation at various points along its physiological pathways and sensitive to external influences. Certainly with some more work out of Pittsburgh, we've seen that there are morphological changes within the bladder discussed this week within 4 to 6 hours of denervation. Furthermore, basic science tells us that there are a number of animal models which can recreate, and please note the recreation is in floating hypothetical question marks, that can recreate OAB. Epidemiologically, assuming the prevalence of idiopathic OAB is about 15%, with 8 billion people on the earth, are 1.2 billion people the same? So I think the question that basic science is asking us is OAB a homogeneous or is it a heterogeneous population? And like the basic scientists did, do we as clinicians, do we need to take a step backwards? Are we asking the right questions? The flip side is, would you guys as a group be happy with the diagnosis of overactive bronchial syndrome or bronchial urgency? If you had a cough for more than 3-4 weeks, which was frequent, may or may not be related to expectoration of mucus, when you go to your GP, would you be happy with being told you got OBS? Or would you prefer OBS asthma, OBS virus, OBS COPD, OBS interstitial disease, and then get targeted treatment? Now, do we need to take a step back? Do we actually start to need to ask the patients, what is wrong? Is there subtle differences with what patients are telling us? Can we wheedle out different patient cohorts? The differences may be subtle, but they may reflect underlying differences in pathology and pathophysiology. Do we need to ask ourselves, are the changes in the bladder physiology, are they pathology? And I'm going to stop there so I don't tread on anyone's toes. And furthermore, do we need to go back further? What is normal? Does everybody here have the same sensation? Are you telling me that 6.8 billion people on God's earth have had the bladders evolving in the same way? Now, looking at this, there has been some work done, and I'd just like to leave you guys with this slide. Now, this is a forced diuresis model. It has its faults, but what we can see is that each shape is a different person. They feel sensations at different points, in different ways. So is this something that we need to work on to progress for the future? So in answer to my first point, do we need to look back on ourselves clinically to move forwards? Thank you very much.